Bismillahirrahmanirrahim. Today we will talk about the psoriasis and psoriatic arthritis. Our today lecture is about the psoriatic arthritis, but we will briefly summarize the manifestation of psoriasis. As we know that psoriasis can involve the skin, it can involve the nail, it can also involve the eyes, cardiovascular system, it can cause enthesitis and arthritis. Now, in the skin, there are white silvery scale on the extensor surface of the elbow and knee. This silvery white scale can also occur on the trunk, buttock, and head, means scalp area. There are five types of the psoriasis. That is chronic plaque psoriasis, pustular psoriasis, gutted psoriasis, palmoplantar psoriasis, and the erythrodermic psoriasis. About the gutted psoriasis, it occurs after streptococcal pharyngitis. And about the erythrodermic psoriasis, this is the more severe form of the psoriasis. Now, the nail manifestation of psoriasis, there will be pitting of the nail. This is the most common presentation. And there will be oil drop sign. This is the most specific sign for this psoriatic nail changes. Onycholysis and hyperkeratosis. At the eye, it can cause conjunctivitis and uveitis. Cardiovascular manifestation of psoriasis, it can cause aortitis and therefore aortic regurgitation. Enthesitis, that is inflammation of ligament and tendon. It can cause Achilles tendinitis and it can cause plantar fasciitis. But we will talk about the arthritis in detail. Now about the psoriatic arthritis. See, psoriatic arthritis is one of the seronegative spondyloarthropathies. And we know that there are four seronegative spondyloarthropathies. And the mnemonic which is used to remember the seronegative spondyloarthropathies, they appear. That is psoriatic arthritis, enteropathic arthritis, ankylosing spondylitis, and the reactive arthritis. We have already a video about the seronegative spondyloarthropathies. Psoriatic arthritis occur in 25 to 30% of the patient of psoriasis. Arthritis can occur before the skin manifestation in 10 to 15% of the patient. The most common joint involved by the psoriatic arthritis is the distal interphalangeal joint. But it can involve any other joint in the body. It can involve the spine, it can cause sacroiliitis, it can involve the small joint, large joint. There are five patterns of psoriatic arthritis. Now, to easily remember these five patterns of psoriatic arthritis, the mnemonic DRAMA is used. Now, D stands for the distal interphalangeal joint. R stands for the rheumatoid-like pattern. And as we know that in rheumatoid arthritis, it involves the joints on both sides of the body. That is symmetrical fully articular pattern. So the second pattern is symmetrical fully articular like the rheumatoid-like. A stands for the asymmetrical oligoarticular. M stands for the multilance. Severe deformity occur in the arthritis multilans, that is telescoping of the finger. And the last A stand for the ankylosing like. But remember, ankylosing spondylitis cause sacroiliitis on both sides of the body, while the sacroiliitis of psoriatic arthritis will be on one side, that is unilateral sacroiliitis. So, if in the question asked about the most common pattern involved by the psoriatic arthritis, that is asymmetrical oligoarticular is the most common pattern. But if in the question asked which joint is involved by the psoriatic arthritis most commonly, that is distal interphalangeal joint. Now for the diagnosis of psoriatic arthritis, Casper criteria is used. Casper criteria has 5 components. The first component is evidence of psoriasis, means that the current psoriasis is present or not. If the current psoriasis is present, it has got 2 points. If current psoriasis is not present, but the patient has previous history of psoriasis, it has got 1 point. And if the patient has family history of psoriasis, it has also got 1 point. The second component is the nail changes. Nail changes if present like anycholysis, hyperkeratosis and pitting of the nail. If any one of these is present, it has got 1 point. The third component is the dactylitis. Dactylitis, either past history or currently dactylitis, has got 1 point. The fourth component is the rheumatoid factor. Rheumatoid factor, if negative, has got 1 point. And the last component is the that for the imaging. If the X-ray show periosteal new bone formation or erosion, it has also got the 1 point. So if the patient has inflammatory arthritis plus 3 of these components, this makes the diagnosis of psoriatic arthritis. Now, what investigation is done for the psoriatic arthritis? So as we know that psoriatic arthritis is an inflammatory arthritis. So the inflammatory marker will be raised, ESR will be raised and the CRP will be raised. And we also know that psoriatic arthritis is a seronegative arthritis. So the rheumatoid factor and the ANA will be negative. And the genetic test which is done for the psoriatic arthritis is the HLA-B27, which is positive in 25% of the cases. X-ray will show erosion, periosteal new bone formation, and in the severe form it can show pencil in cup deformities. And the uric acid will be raised because there is increased cell turnover in the psoriasis. Now the treatment of psoriatic arthritis. Psoriatic arthritis is treated in the same way as we treat the rheumatoid arthritis. So we can give the NSAIDs, non-steroidal anti-inflammatory drugs, if there is limited disease. But remember that steroids are contraindicated in psoriatic arthritis. Because if you treat psoriatic arthritis with steroids and you want to taper the steroid or withdraw the steroid, it will cause the pustular psoriasis. If there is moderate to severe disease, we can start DMARDs, and we know that there are 2 types of DMARDs. One is synthetic DMARDs and the second one is biological DMARD. The synthetic DMARD include the methotrexate, hydroxychloroquine, lepelenamide, apremilast. Methotrexate will help skin issues as well as the arthritis component. Hydroxychloroquine, which is a DMARD but also an anti-malarial, is contraindicated in psoriatic arthritis. because it will worsen the psoriasis. We can add the lipronamide, which is also a synthetic DMARD, and the antidote for the lipronamide is cholestyramine. Lipronamide causes toxicity. The antidote is the cholestyramine. And what is the antidote for the methotrexate? That is polinic acid, also called the leucovorin. And hydroxychloroquine is a contraindicated here. But what is the main side effect of hydroxychloroquine? That is retinopathy. And we can also give the apremilast, which is also a synthetic DMARD. It is a phosphodiesterase 4 inhibitor. It will prevent the cytokines and therefore the inflammation. Now the drugs which are contraindicated in psoriasis are, if given in psoriasis, will worsen the psoriasis. The mnemonic for these drugs are the PLAB, P-L-A-B. P means painkiller like NSAID. L means lithium. A means anti-malarial like hydroxychloroquine. And A means ACE inhibitor. A also stand for the alcohol. Alcohol also worsens the psoriasis, will trigger the psoriasis. And B is for the beta blocker. So these are the drugs, if given in the psoriasis, will worsen the psoriasis. Now the biological demand which is used for the psoriatic arthritis include the anti-TNF, that is adalimumab, infliximab, etanercept, sertolizumab, and golimumab. And the IL-17 inhibitor include the secukinumab and ixekizumab. The combined IL-12 and IL-23 inhibitor ustekinumab and the JAK state inhibitor tofacitinib. So these are the biological demand which are used in the psoriatic arthritis. This was a video about the psoriatic arthritis.